Commissioners Agbabi Aka. Commissioner
Present.
Yes. Okay. Commissioner Bandari,
Here.
Commissioner Blake,
Here.
Commissioner Cheatham, Commissioner Douglas, Commissioner Desarasa, Commissioner Foreman,
Here.
Commissioner Gelrud, Commissioner Gelrud, Commissioner Gilmore.
Here, sorry, it's Gelred.
Okay, Gelrud is there. Gilmore,
Here.
Commissioner Jensen is here. Commissioner Spinner,
Here.
Commissioner Stroughton Duncan,
Present.
and Commissioner Wang.
Here.
Okay. We have two items on our consent agenda. Approval of the public session minutes from the October 16th, 2025 Commission public meeting. And data reporting by non-hospital healthcare facilities. These regulations were approved during the July meeting as proposed regulations, and there are no substantive changes. Does any commissioner wish to remove an item from the consent agenda? Hearing none, is there any objection to adopting these items on the consent agenda? Hearing no objection, the consent agenda is adopted. So agenda item number 2 is update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Okay, well, Dr. Jacobs, please provide us with any updates that are not included in the monthly updates.
Sure. Thank you, Chair Boyle. So I wanted to highlight a few areas in particular. The first is I'm excited to say that Maryland has submitted their application for the Rural Health Transformation Fund to CMS. And so that application went in towards the beginning of November, a couple of weeks ago. And there's really 3 parts to this application in terms of what the state is asking CMS to fund. The first pillar is transforming the rural health workforce. The second is promoting sustainable access and innovative care for rural Marylanders. And the third is empowering rural Marylanders to eat for health. And so those proposals and our submission is now available online for any folks who want to read through, and it's provided in the update of activities. There's a link that you can click on to go look at it further. Essentially how this will work is the states are supposed to hear back from the federal government by December 31st as to how much funds are being awarded by CMS. There's a certain amount that every state is expected to receive, which is around $100 million per year. And there's a certain amount that is competitive based on CMS's scoring of our application, which adds to about another $100 million. And so once we hear back from CMS, potentially funds would be dispersed and work would start. So there's several areas to highlight there for MHCC in particular. We have an oversight role on the provisions related to HIT connectivity. That includes supporting rural provider connectivity, community-based organization connectivity, the closed-loop referral tools that connect providers and community-based organizations and making them interoperable was a part of that. There's also, this is part of the immediate impact funds. There's also a portion of that related to telehealth. And the way that this application is structured, there's immediate impact funds, which would go directly to CRISP in some instances as the state designated healthcare utility, and with MHCC oversight. And there's other funds that would be designated for the Maryland Department of Health and other agencies to have a competitive grant application process to administer these grants. And so that is one, I think, important update. The second is, or actually, I can pause there in case there are any questions. Any questions related to the Rural Health Transformation Fund? Yeah, go ahead.
Yeah, what happens? Who had the question? I'm sorry.
Sorry, this is Aaron. I wanted to ask about the closed loop referral.
Sure.
What is the vendor that would be used for that? Has that been determined, or is it just the vision is to use a vendor and then we'll figure the rest out later?
So I'd say the application itself is somewhat vague as to how we accomplish the goal of closed loop referral interconnectivity. One could imagine that there are standards now developed for how the different tools can talk to one another. This is a challenge because if one CBO is onboarded onto one tool, a lot of these community-based organizations are small, don't have a lot of administrative know-how. If they spend the time and effort to onboard onto one tool and can only talk to certain providers or plans, it's probably going to be hard for them to onboard onto another tool. And if the tools don't talk to each other, it becomes an issue. So I think looking to achieve interoperability between the tools is what was talked about in the application. But I think it's going to take some going through to figure out what the best strategy is to move forward as a state there.
Any other questions? What happens, my question is, what can we do? Because this is all critical for the state, for the rural areas. What happens if we don't get this?
So, well, I'm gonna knock on wood. We're answering, but the way that the legislation was structured for this, and I don't know all of the details, but there should be a certain amount that every state can get. That competitive portion that I had at the beginning, it will likely be related to the relative rurality, the ruralness of a state. And Maryland as a state is less rural overall compared to other states. But some of that has to do with the overall competitiveness of our application too. So I think that the team at MDH is leading this. We are supporting it any way we can. And I guess we'll just have to see how much money we get.
Okay,
Yeah.
we will get something.
Yeah.
Sounds great. Well, thank you, Dr. Jacobs.
Yeah.
So Dr. Jacob, is there anything they're going to do to attract workforce in these rural areas? Because typically
Yes.
the payments are much lower than compared to, metropolitan areas.
Yes. So that first pillar that I talked about, transforming the rural health workforce, there's several provisions related to training and retaining workforce in rural areas. Some of that is through the Department of Labor, like expanding existing programs, and there's several programs at the Maryland Department of Health that focus on workforce retention.
Is their payment is going to be higher or not? Because I can tell you in reality, providers, even the social workers or, psychologists or any mental health professionals, unless there is some incentive to work in those areas, it will be difficult task to recruit them.
Yeah, that's a great question. So I'm doing this from memory, so I won't be able to recite everything because it's a decently lengthy application. But there are some provisions related to primary care providers and other specialty providers to make sure that they get established in rural areas and also that they can expand their practice to serve more people and have more advanced uses of health information technology so that patients can, for example, do patient portal messaging. So those are payments to providers in a sense in rural areas. And I just wanted to invite also David Sharp. Do you have any else?
Yeah, so thank you, Dr. Jacobs. I think, good afternoon, commissioners. I think just briefly to expand upon that, these also serve to put infrastructure investments in. For example, it could be bringing your EHR up to current standards. It could be expanding on your interface connectivity with CRISP to support things like, as Dr. Jacobs mentioned, the closed loop referrals for the interoperability. It could be implementing telehealth solutions within the practice itself, where you don't have the ability today to set up either a room to support telehealth or have the necessary equipment tethered to your EHR. So there are some other additional technology elements that these funds would be able to help practices directly expand to implement or expand on what currently exists. Thank you. Yes, sir.
Thank you.
Okay.
Any other questions? No. Mark, do you have anything?
Just one other piece. I wanted to mention on the, in terms of the AHEAD model implementation. The Maryland Healthcare Commission continues to participate in the regulatory working group. This was created in response to a governor's directive. And MHCC participated in 2 listening sessions related to cost shifting policy and Medicare Advantage stabilization. And the next steps there are that draft proposals will be displayed before the public. The Maryland Healthcare Commission, as part of AHEAD, some of what we are leading.
Actually, I'm in a Zoom conference call right now.
Excuse me.
Shall I call you back on?
Please mute.
Is this your cell number that you're calling from?
Yes. Mute.
Okay, I'll call you back after the meeting's over. It should be.
Whoever's taking a call, we can hear you.
Okay, great. Yeah, just everyone make sure that you're on mute. Thanks, everyone. So the Maryland Healthcare Commission is part of this regulatory working group. Some of what we are doing is we're running the primary care investment work group. That work group, we are going to start holding meetings in December again related to the development of the primary care investment targets. Also related to AHEAD, CMS and Maryland have now signed the state participation agreement in AHEAD. So that's really important, an important milestone, because CMS and the state have been negotiating this agreement for some time. So I wanted to mention that because it sets us up for the now implementation collectively of the model, which is really across state agencies, across stakeholders. So many of you on the call will play a part in that work. So really thanks to everyone who took part in that. And I think with that, maybe that could be the highlights for today in terms of the update of activities.
Well, thank you, Dr. Jacobs. Any further questions before we move on? Okay. For agenda item number 3, which is the AAMC Surgery Center, Annapolis Ambulatory Surgical. The AAMC Surgery Center is the existing ambulatory surgery center located in Anne Arundel County, seeking to establish an ambulatory surgical facility with 3 sterile rooms and 1 non-sterile procedure room upon project completion. Now, Bill Chan, program manager, will present the proposed project. And I also want to mention that this is the last meeting that Bill will be presenting at, because he is actually going to be retiring at the end of the year after 30 years. So quite the accomplishment.
Thank you so much for your service, Bill.
Thank you again. And thank you, Madam Chair. And good afternoon to commissioners. The request before the commission today is for a certificate of need by Anne Arundel SCA Surgery Center, doing business as AAMC Surgery Center, Annapolis, to establish a freestanding ambulatory surgical facility in Anne Arundel County. Next slide, please. AAMC is an existing ambulatory surgery center with 2 sterile ORs and 0 non-sterile procedure rooms. Calendar year 2023, AAMC recorded 24 surgeons who performed surgical procedures at this ASC. The applicant seeks to establish an ambulatory surgical facility by renovating available space and adding a 3rd OR and a procedure room. On project completion, the facility would operate with 3 ORs and 1 procedure room. Next slide, please. From calendar year 2021 to calendar year 2024, the number of surgical cases performed at AAMC increased by over 214%, with the number of total joint arthroplasty procedures increasing by over 254%. The applicant's demographic data shows that the population aged 60 years and older is projected to increase to over 27% between the years 2020 to 2045. AAMC indicates that about 73.2% of the patients it serves fall into the age group 60 years and older. Due to the susceptibility of injury and the onset of conditions which require surgical intervention, AAMC expects an increase in surgical case volumes and in performing joint replacement procedures. Therefore, the applicant's data supports the expansion of the existing facility. Next slide, please. The renovations will include space for a nurse's station and several supportive areas. In addition, AAMC staff will grow with the addition of 7 orthopedic surgeons and 1 pain management specialist by calendar year 2026. The applicant demonstrates that AAMC's 3 ORs will each operate at optimal capacity by calendar year 2027, second year after project implementation. Next slide, please. The project cost is a little under $4.2 million, which includes $3.5 million in renovation costs, $250,000 set aside for contingency and inflation allowance, and $400,000 in financing costs and other cash requirements. The applicant has verified that Anne Arundel SCA Surgery Center has $2.2 million of cash equity for the proposed project and submitted a letter of credit with Truist Bank for a 10-year term loan of $2 million. AAMC's revenue and expense statement indicate that the ambulatory surgical facility will break even and turn a profit by calendar year 2026, the first year of operation after project completion. Next slide, please. While the proposed project complies with the General Surgical Services chapter of the State Health Plan and with the CON General Review criteria, staff recommends that the Commission approve AAMC's application for a certificate of need with the following 3 conditions. Next slide, please. To comply with the charity care standard, staff recommends a standard condition that is issued with the establishment of a new ASF that the applicant provide charity care in the amount required by the standard. For the second and third conditions, staff recommends these 2 conditions regarding the submission of data to the Commission. To comply with the quality of care standard, the applicant shall provide the calendar year 2023 and calendar year 2024 performance data, 8 quality measures, and 2 claims-based measures. To comply with the health equity criterion, the applicant will collect and report annual data for the next 3 years on the enhanced pre-operative education pathway. And the final slide, please. In summary, staff finds that with the conditions in place, the applicant complies with the applicable standards in the State Health Plan and has demonstrated the need for the 3rd OR. The project is financially feasible, cost-effective, and will have a positive impact on the healthcare delivery system. Therefore, staff recommends that the Commission approve the AAMC Surgery Center Annapolis request to establish an ambulatory surgical facility with 3 ORs and 1 procedure room with the conditions as discussed. Before I conclude, I'd like to introduce members from AAMC who are on virtually. First is Kamari Shade, Group CEO, SCA Health. Christine Lowther, Market Vice President, SCA Health. Jake Lombowski, Director of Finance, SCA Health. And Counsel Howard Solins and Jack Heller with Baker Donaldson. With that, I conclude and I'm ready for any questions you may have.
Well, thank you, Bill. Do I have a motion to approve the AAMC Surgery Center Annapolis ambulatory surgical?
So moved.
Second.
Joan? Second. Jensen, Commissioner Jensen. And is there any discussion?
Is this a part of Arundel Medical Center or a separate entity who has the surgical center?
Dr. Bandari, this is Howard Solins from Baker Donaldson. Luminous is a majority owner of the ASC. There's an organization chart attached to the decision And Anne Arundel Medical Center is a participant. Luminous, the system, is a participant in the ASC ownership.
Is it for profit or non-for-profit? Because Luminous Health is, I think, non-for-profit, right?
Right. I don't represent Luminous. I don't know whether or not it's considered a not-for-profit or for-profit. I don't know. Chris, do you know the answer to that question?
Yes,
Howard.
the ASC is for profit.
Howard, in the application, you've identified as a for-profit corporation.
Okay.
Thank you.
Is there further discussion?
I have a question, not necessarily specifically about this entity, but more so about whether we've looked at small ASCs that within 3 to 4 years go through the CON process for expansion and what the trends are there, right? Because I know we have sort of an unintended consequence of the rules of the CON process, and I'm just trying to figure out how inefficient we've made it for the market by having that in place.
Thank you for your question. I guess for clarification, what do you mean by trends, I guess? What do you, try to identify?
Well, I'm trying to figure out if we did a historical look back at the makeup of the ASC market. We know we're flooded with ASCs in Maryland. I'm trying to figure out how many start small and maybe would have just started bigger, but couldn't because of that requiring CON, and then they come in for expansion after the fact.
For clarification, ASCs are basically facilities that have 2 ORs or less. An ASF, ambulatory surgical facility, is a facility that has 3 ORs or more. Now, I won't go through the long history of changes in the rules, but we've had a number of applications recently. I wouldn't say that it's a flood of applications, but there are a number of applications that have been submitted, or at least inquiries as to expanding from 2 to more than 3 ORs or more. With that, usually these are facilities that have had a growth in surgical volumes, which means surgical cases in minutes. They've recruited additional physicians to perform surgical procedures. I can't tell you if there's a certain specialty or a certain number of specialties that are inquiring as to this expansion, but orthopedic surgery seems to be a primary specialty because of the nature of the surgery. It takes a while, usually about 90 to 100 minutes surgical time per case. And obviously the complexity of the surgery, the other specialties may not be quite as long, maybe general surgery, but usually it's orthopedic surgeons that seem to be inquiring as to the expanding of services. As to any other reason besides just the fact of having accessibility to a whole operating room and scheduling time, which they may not be able to acquire in a inpatient setting, or just the nature of the fact that insurance companies are moving towards outpatient facilities in general for reimbursement purposes, and more surgical procedures are being allowed to be performed in an outpatient setting. That, I think, is some of the reasons why they are inquiring as to expanding to these ASFs. I hope I've answered your question. I'm not sure if that's a complete answer, but it's a start.
Yeah, I think it's less about the rationale, and I would like to start with just seeing what the data tells us. But that is helpful context, so I appreciate it.
What is the data that we're looking for? Just, are we giving, you're trying to figure out if we're giving too many certificates of need and therefore preventing other people from expanding? Is that what you're getting at?
No, I think, and I'm willing to be corrected here, but I think that there are a lot of ASCs that start small in order to not go through a CON process and then subsequently seek to add capacity, when if the CON was at a different level, they may have just started at what they envisioned in the first place. And I think if we looked at the progression of those ASCs in the market, we would be able to tell if that is actually the experience that we're seeing.
But I'm just trying to figure out if, when we get that answer, what does that do for us?
I think we should have a conversation about the requirements and when CONs are required and whether we are regulating at the right level, I guess.
That's helpful.
Well, we did a study in June that was just on the ambulatory surgical centers in Maryland. And I think, I don't think there was a conclusive, there was any conclusions made on whether, I think what you're asking, and maybe I'm hearing it the wrong way, but is CON a barrier to having larger more surgical centers with more operating rooms? And I don't think it is. It seems to me that they start small so that they can build their volumes. And then when they get to an acute, a tipping point, that's when they come. So I don't, because you're right, there's significant, that study showed there's significantly more ASCs, which is a 2 OR facility, than 3 and more. But I think it seems to be a natural progression and not necessarily a barrier, is how I interpreted that study. But having said that, we do an annual survey of ambulatory surgical centers that includes ASCs and ASFs, and to the extent we can gather data on that and start to trend that, I think that's something that we could certainly roll into the surveys that go out.
Yeah, I don't mean to take away from the applicant's time here, right? Like I'm not trying to derail us, so we can probably put it to bed. It was less about are we creating a barrier? It's more about, is it inefficient to have a lot of small ASCs that are capital intensive, right, in the market when we potentially could have larger facilities?
And if we're gonna when we gather that data, I think it would be very important then to identify them by ownership, because anecdotally, my experience has been the smaller ones are owned by physicians and the larger ones are owned by healthcare facilities or private equity, other folks. And that's an important distinction as well, because, do we want to encourage more physician-owned facilities or more healthcare organization or private equity groups coming in? And I think that's a discussion worth having as well.
Just to build on that.
I'm sorry, because again, anecdotally, folks are not familiar with, they start out small because that's capital they've got. And then, so it's got nothing to do with certificate of need, and they get the capital, they get started, they're making that work, and then they can go a little bit bigger. That's the doctor groups. The other groups are doing different things. So that would probably be an important data, sorry.
No, and just on that point, we are seeing a lot of changes in ownership of ASCs.
Yeah.
We are having a lot of those applications come in for change of ownership. And so maybe they start out as physician owned, and over time they're changing.
Well, that's sort of a business model, right? You start one out, build it up, somebody else buys it from it. But
Yeah.
that's all important information to get and then factor into that.
Yeah,
I would think.
It's such a great discussion. I now have a follow-up question for Mr. Howard Salins. So I see the ownership is part by Luminous Health and part by the physicians, 28, which going to be 32. Are these physicians are the only one performing surgeries in that? So ownership is decided by who are the working in that surgical center, or it's open for anybody?
I believe, and I can be corrected by the operational folks, but there are surgeons who are not equity owners who are performing services at the surgery. It's not limited to those with equity participation.
But those who are those who have ownership, all of them are doing surgery there, right?
Mary, what do you think?
Yes, they are. This is Chris.
Chris.
You have to do surgery at a surgery center to have ownership.
Got it.
But
That's
there are
a
people
incentive
doing,
of bringing more cases to your center because you have ownership.
but there are people doing surgeries at the centers who do not have an ownership interest, correct?
Correct.
Bill, I have a question. Was a few years ago, we actually changed the CON for the ambulatory surgery center, didn't we? Right?
Yes.
1, 2, 2 operating rooms before they need a CON.
That's correct. You have a very good memory. It's gone through a number of transitions, a lot of different changes. I think in 2018, you went from 1 to 2. Is that right? Or maybe it's I can't remember the exact years,
It
but
was 1 or 2, yeah. I had just
Initially-
come on. It was to 18.
it was initially 1 OR would be, and again, the term was used, physician office surgery center. To show the need for physicians to have a place where they could perform surgery and receive reimbursement for the procedures. Then we expanded to 2 ORs, and that would be an ambulatory surgery center instead of 1. And that the threshold for a ambulatory surgical facility would go from 2 ORs. Again, this is confusing, I know,
Oh, no, but
to 3 ORs would make it an ambulatory surgical facility. I think that was 2018 or 2021.
It was either 18 or 19, and I believe it was a result of the work of this certificate of need, the streamlining group. So
exactly, 'cause I
that
remember that was a streamline.
it was a streamline. It was so I believe, you know, the statutory process is certainly amenable to like how the market shifts, and that's a perfect example of how they accommodated the 2 ORs versus to limit the number of CONs that people had to submit for. So, I mean, it's a dynamic process, and I think as we get more data, we'll figure out, you know, what we want to do. But that was definitely a result of the work of this commission and the streamlining efforts.
Okay, thank you. Any further questions? Well, we have a motion. All in favor?
Aye.
Anyone opposed? Okay, the AAMC Surgery Center Annapolis Ambulatory Surgical is hereby approved.
So let me thank the staff for all their work and for being available not only to analyze the information but get on calls with us. We had robust conversations and we're able to satisfy the standards, and we appreciate the work of the staff.
Thank you, Howard.
And just to close, I just want to thank the commission and the commissioners. It's been an honor and privilege to work with you. And I look forward to seeing what the commission does in the future.
And we wish you
Thank
the
you.
best, the best.
Okay, agenda item number 4, 2026 MCDP data submission manual. The Maryland Healthcare Commission is required under COMAR 102506 to publish the medical care database, MCDB, data submission manual on an annual basis by November 21st of each year. This manual provides specifications, technical information, and recent updates to payers for the reporting periods in the subsequent year. For posting of the manual on the commission website, the manual is presented to the commission for approval. Kenneth Yates Trotman, Director of the Center for Analysis and Information Systems, will give an overview. Kenneth, please
Thank you,
proceed.
Chairwoman. Good afternoon, commissioners. Next slide, please. What we're going to talk about today is give a background as to why we're actually doing this presentation today. Also give an overview of the MCDB, which is a portal data submission. For example, who's required to report to the MCB, and then to give an overview of the new updates that are included in the data submission manual, and also the purpose of the alternative payment model data collection, which is a different submission than the portal submission, and also the changes that are associated with those APM data collection, which is a template and an Excel manual submission. And then we'll round it off with next steps. Next slide, please. So why are we actually required to actually do this? Now, the Maryland Healthcare Commission is required under Regulation 1025 or 615 to make the data submission manual available to payers on or before November 21st of every year. Now this manual will be used by payers in the data submissions, and the manual is a list of specifications, very technical, to really submit that data in the subsequent year. The manual, once approved, regulation requires that the manual to be timely posted on the commission website to make available for payers and others. Next slide, please. So as an overview of the MCDB, which is a portal submission, meaning that it's actually submitted to our data aggregator OnPoint health data. The information that we collect are from primarily commercial payers or private payers and 2 public payers in Medicaid and Medicare. So regarding for commercial payers, for entities that have at least 1,000 lives or more, as reported in the MIA via the report on Maryland lives, are required to report to the MCDB. Now, these private payers are composed of life and health insurance carriers and HMOs, third-party administrators, PBM, and behavioral health administrators. Most of the information that are collected here are for non-ERISA plans in these 3 entities. We also collect data on qualified health plans and qualified data plans under the ACA. We don't have any pure qualified health plans, meaning that we have, those are payers who only sell or provide coverage for qualified health plans. They are no longer ethics. So insurance companies and HMOs sell a combination of non-compliant and qualified health plans. The information that we
I think we can still hear us, Ken. Yeah.
Okay, so the information that we report comes in the terms of a membership or eligibility file. And the eligibility file, meaning that if you have health insurance or in Maryland under the private for privately insured, you would be, and you live in Maryland, you would be in the eligibility file. If you live outside of Maryland and your contract was written or sold in Maryland, you will be in the eligibility file. So eligibility file means that you are eligible to use your medical benefits. Now, it so happened that unfortunately you use your medical benefits, that information would be in the form of these claims files. If you go to a physician or a professional provider, your information would be in.
I think we're having a technical difficulties, but it will be back soon.
Okay.
Your information would be in the professional services file. If you go to a hospital or facility, your information would be in the institutional services file, which include inpatient and outpatient data. If you go to a pharmacy to fill your prescriptions, it would be in the pharmacy or prescription outpatient drug file. And lastly, if you go to the dentist, it would be in that dental file. Albeit that for dental services, it is very limited to the qualified dental plans under the ACA. Now, we also have a provider directory file, which includes a provider ID, provider DA number, and things like the federal tax ID, last name and first name and credentials of providers. Now, one of the use cases that we use this provider directory for is to that we QC the provider ID. We want to make sure that all of the IDs that are in the professional and pharmacy file are actually real. So what we do, we use all of the IDs in the provider directory to make sure that they are in the professional services and pharmacy file. Now, these have to match 100%. If it doesn't match, the file will fail and the particular data submitter will have to try again. Now, the other pair that we have is the Medicaid managed care organization and fee-for-service data that is provided by Medicaid via Hilltop. And also we provide Medicaid a copy of the privately insured data, so that they could have it. So that is the kind of the agreement that we have. They provide us all the Medicaid data, and we provide the privately insured data. We also, and these, I have to note that the Medicaid data comes in SAS data sets ready to use. they are already QC'd. So any staff or data users could actually use those information immediately. On the Medicare fee-for-service data, we get this from CMS via a state agency gateway, and these are also ready-to-use data sets. One may ask, could you go back one slide, please? One may ask, well, where is the Medicare Advantage file data? The Medicare Advantage data is provided by the commercial carriers. Could you go back one slide, please? Please go back. Thank you. All right, so now we're up to what information, new information we have in the MCDB. Well, this time around we add two variables or two columns. The first one we add is the state health plan indicator. And this includes a flag to identify enrollees who are enrolled in the state health plan, primarily state employees. Right? And the reason why this is so important is because all the information that we have analyzed using APCD, we have to break out. We usually break out the state health plan. All of the mandate studies that will follow and residency studies that will follow this presentation, you'll see that breaks out the state health plan. And we want to look at, we want to identify who are the actives. Also HSCSC, when we actually provide reporting on commercial per capita spending, HSCSC would like us to actually break out the actives for that reporting as well. So that's the rationale why we are including an indicator in the MCP for 2026. The other variable that we have is the pre-authorization indicator. Well, this is an indicator that identifies whether a claim requires prior authorization or not for medical, dental, or prescription drug services. And the rationale behind this is that under Chapter 847, House Bill 932, and 848, Senate Bill 791, MACC is required to report on prior authorization frequencies and adverse decisions. I know Dr. Jacobs, you might have a comment there.
Yeah, thank you. So on this provision in particular, MHCC is participating in an adverse decisions work group. Just yesterday, it came up that folks were interested in not only services that are paid, but also denied claims. And so this could be an area that we look at in the future too, not for this submission manual, but potentially in the future. Thank you.
All right, next slide, please. So we on to the 2026 alternative payment model. So the purpose of this is that under Chapter 298, Senate Bill 834, and Chapter 297, House Bill 1148 of the 2022 laws of Maryland, which enable payers and providers to engage in capitation and two-sided risk contracting, and which was signed into law on October 1, 2022, requires MACC to collect and aggregate value-based care data and develop an annual report to answer 5 questions. The first one is to find out the number of and type of value-based arrangements, and also the quality outcomes of those value-based arrangements, the number of complaints regarding value-based arrangement, which will be collected by the NIA, and also the cost effectiveness of those value-based arrangements, and also the impact on two-sided incentive arrangements on physician fee schedules. Next slide, please. So what changes that we have in the APM data collection template? And this is a template, meaning it's a non-portal data submission. It does not go to our data aggregator endpoint. It is received here by staff, right at the commission in the form of Excel files. Pretty manual, and actually very, very robust but manual submission. So for the APM data submission manual, what we have added 4 new quality measures for a total of 10. We use these to calculate quality scores using payer submission data to the MCDB. Technical specifications shall align with those provided by the National Committee for Quality Assurance. On the primary care data submission manual, the purpose of this manual is to have a wider or support a broader reporting requirements for non-claim spending. For example, supporting the primary care investment targets for that legislation. Also, for this manual, we have added a billing provider fields. Previously, we have collected data on actual non-claims payments based on the payer level, but this time around we are actually looking at billing provider level. Payers shall use the expanded non-claims payment framework and the ACP LAN framework crosswalk to categorize their non-claim payments to primary care. Next slide, please. As far as next steps are concerned, we will invite commissioners for any questions. You vote to post the submission manual on the commission website to make it available to peers and others. And we will be disseminating this manual and follow up with peers in a training in early January to talk more about the changes in this manual and find out what other questions our data submission have, and to thank them for the due diligence of not only for this manual, but to answer questions on previous submissions. All of these changes will be implemented starting in the first quarter of 2026, and that data is due at the end of March in 2026. And that ends my presentation.
Well, thank you, Ken. Do I have a motion to approve the 2026 MCDB data submission manual?
So moved.
This is Commissioner Duncan, second.
Johnson, Commissioner Duncan. Second. And is there any discussion? Questions?
Hi, Commissioner Galbraith. Can you just summarize, please, what will be better with these changes? Like, how do these changes translate to something actionable and usable that we need to know? I'm a little trying to follow the technical part, and I just need help.
All right, so if we go back to one of the slides where we have these two rivers, I think the slide. Slide 5. You know, where we talk about one more. Yes. So where we talk about adding two columns, right? The first one is the state health plan indicator. Now, all of the information that we use, all the analysis that we use using the MCDB, we have to break out this state health plan. Now, we have no easy way of accurately doing that.
Got it.
So we create this flag so it would make it easier for analysts to break out, especially the actives. Because right now, we do identify the state employees, but it includes retirees as well. So we want to break out the actives. So this flag will allow us to actually do that.
And would that then be something we would want to do something about? Meaning, if they're using more services, less services, sicker, healthier, would that lead to some change in how care is delivered?
Well, it leads to reporting, especially with mandates. Now, when you see all of the mandates reports and legislative reporting that you'll see following this presentation, you will notice that we are breaking out the state health plan as well. Because as you know, for mandates, although the state health plan is a self-insured non-ERISA, plan, which does not really affect, mandatory report. But since it's the state, we actually adopt those mandate changes, mandate actually changes. So it is crucial that we able to accurately identify the state health plan.
And that could lead to some policy changes that, like, for example, state health plan, if, this is just totally made up, but they could have like, we could see that there's higher rates of diabetes with complications. And then that could lead the state health plan to think, okay, well, how do we need to change our benefit designs and like
That's what I
policy
wanted to
approaches?
do.
Like,
Yeah.
yeah.
It's great. Okay.
And the other one is a legislation that requires MACC to report on prior authorization frequencies and advance decisions. So we're creating this flag to identify what claims actually require prior authorization.
Okay.
And maybe just as an example there too, like a lot of questions come up, it's like, what kinds of services are being prior authed? And we could look at the claims after this and actually have an accurate answer to that question across payers. Whereas right now that's kind of challenging to decipher. Yeah.
Thank you.
Yeah.
Okay. Any other comments or questions? Okay, well, we have a motion. All in favor?
Aye.
Okay. Thank you. Thank you, Kim. Sorry. Is anyone opposed? Okay, the 2026 MCDB data submission manual is hereby approved. Thank you. Okay, agenda item number 5 will be mandated benefits study for HB 1217 SB 085 2023 Maryland Medical Assistance Program and Health Insurance Coverage for Biomarker Testing. House Bill 1217 of the 2023 legislative session passed the legislature and went into effect on January 1st, 2024. The commission is required by the legislation to report to the Maryland General Assembly on the impact of providing biomarker testing coverage on public and private insurance. Additionally, the legislation requires an analysis of the impact of providing access to biomarker testing coverage of individuals based on race, gender, age on public and private insurance. Commission staff contracted with the Hilltop Institute to evaluate the impact of requiring biomarker testing coverage. Laura Spicer and Todd Switzer with Hilltop will present the findings of the study before asking the commission to approve the report. So, Laura and Todd, up there. Okay.
Great. Thank you so much for the introduction. Good afternoon, commissioners and Dr. Jacobs, and thanks for inviting us here today. I'm Laura Spicer with the Hilltop Institute at the University of Maryland, Baltimore County, and I'm joined by my colleague, Todd Switzer. Todd, would you like to introduce yourself?
Certainly. Good afternoon. I'm an actuary at Hilltop, and thank you for this opportunity.
Great. So next slide, please. So today we will provide some background information on the study, present the results of a survey of the commercial health insurance carriers in Maryland, present some utilization data, and then present the results of financial modeling. Next slide. So first, a little background information. Next slide, please. Right, so Maryland broadly defines a biomarker in statute, and we have that statutory language listed on this slide. And I'll come back to this point on this broad definition in just a moment. But providers may use biomarker tests to check for gene or chromosome changes that impact the risk of developing a disease, to help plan treatment, to determine the impact the treatment is having, and to make prognosis. And they're commonly used in cancer treatment. Next slide. So as noted, the General Assembly recently expanded coverage requirements for biomarker testing for both Medicaid and state-regulated health plans. So legislation requires insurers to provide coverage for biomarker testing beginning January 1st, 2024. And required coverage for Medicaid was phased in, starting with cancer testing in 2023, and then expanded more broadly to include other types of tests effective July 1st, 2025. Then the legislation also required a couple of studies. So first, it required Medicaid to submit a study estimating the cost of expanded biomarker coverage, and this report was due in 2024. And then it requires MHCC to submit a similar study by December 1st of this year on the impact of providing access to biomarker testing to individuals based on race, gender, age, and public or private insurance. And so that's why we're here today. And Hilltop supported on both Medicaid and MHCC for both of these studies. Next slide, please. So for some additional context, Maryland is not the only state requiring biomarker testing coverage. 17 other states also require coverage for all state-regulated plans, and 4 other states have narrower laws applying only to certain plans. And there's just generally been a lot of recent state legislative activity around biomarkers. Next slide. So for this study, we collected survey data from the insurance carriers, and then we also analyzed claims in the all-payer claims database. So looking at the survey data first, we designed a short survey in collaboration with MHCC staff, and we also received feedback from the Maryland Insurance Administration. We administered it over the summer to the 5 commercial large group carriers in Maryland, and we specifically asked about their largest HMO and PPO plans. And 4 of the 5 carriers responded to the survey.
Who did not?
Kaiser Permanente.
Got it.
Great. So we asked questions about utilization of biomarker tests to date, associated costs, and we were initially hoping to use these plan reported costs to inform our modeling, but as we'll talk about in just a moment, we turned to using APCD costs instead. And we also asked about forms of utilization review. Next slide. So just a quick overview of the findings. All carriers apply some form of utilization review for biomarkers, and with prior authorization being the most common. We also asked about claims volume to date, which varied significantly by carrier, with one carrier reporting having no claims for biomarker testing during the time period. But based on the reported data, about a quarter of the biomarker testing claims were denied, with the main reasons for denial being around medical necessity, lack of documentation, or out-of-network providers. We also asked about average cost per test by disease category, and we saw a wide variation across carriers. So for one example, for the average cost of cancer biomarker tests ranged from $99 to $1,500.
Laura, I'm an oncologist. This is music to my ears. Average cost is $5,000 to $20,000.
Good. Great. Thank you.
I will go over. I looked at all data very carefully yesterday. Thank you.
Great. Thank you so much. Yeah, so wide variation, and we thought maybe this could be because some are covering more expensive tests, but coming back to that definition, the definition in statute is broad, so the carriers might be applying kind of different criteria as to what they're counting as biomarkers. Next slide. So then we looked at service utilization in the all-payer claims database. Next slide. So we looked at 2024 data, so that corresponds to the start of the coverage expansion, and it was also the latest year of data available. So we looked at the large group fully insured and the state employee markets. And as Ken noted in his prior presentation, the state employee includes retirees. And again, as noted earlier, the definition of biomarkers in statute is broad and may include things like more routine lab tests. So we tried to focus the analysis on the proprietary tests that were unlikely to be covered prior to the statutory expansion. And we consulted with clinicians at Medicaid to help us identify the codes. And we grouped these biomarker tests into 7 disease categories. So big picture, I'm looking at the markets, we found Just over 7,000 large group enrollees had a biomarker test in 2024, costing $3.2 million during that year. And for state employees, just under 6,000 had a test, totaling about $2.5 million that year. So next slide. So the next couple of slides show utilization by various demographic characteristics. So this shows utilization by gender. And females accounted for about 68% of biomarker test utilizers in both markets and about 75% of total claims costs. An average cost per female utilizer was higher than for males in both markets. And I just wanted to note on this slide, the counts for males are suppressed in this table because the missing category had small cells, so we had to suppress 2 rows of data. Next slide. So this shows the data by age group, and adults aged 40 to 64 accounted for the largest share of biomarker testing, about 55% in both markets, and about 58% of total claims cost in both markets. So now I will turn the mic over to my colleague Todd to present additional data and the financial modeling.
Next slide, please. So before we go to a more macro level, we did want to finish kind of the demographic look and start with the 2 pieces of the commercial market you see here, large group fully insured and state employees. We have sorted by from highest number to lowest by race and ethnicity here. I wanted to highlight over to the right for the white population over the furthermost right column. Out of the total pool of the commercial large group market, the entire market was that 493.17, 4th column from the right. So that's kind of where I ground things. If we had 100% utilization, everyone got a biomarker test, it would be this 490, at least in 2024. So as we stratify the market, over again, back to the furthermost right column, 2.3% of the white population got a test in 24, as we're just starting the program 1/1 of 24. And how that compares to other races there is a distinct difference. When you look at African Americans, 1.2. Again, I'm looking at large group, 1.2 Hispanic, 1.4 Asian. So about double the uptake so far in the white population. Again, highlighting Laura's number from the previous slide, the first column there. So far, 7,200 people out of the 490, I'll call it the universe, got a test so far. So that's 1.5%. And just again, just trying to give some tangible sense of how this has gotten off the ground. Yeah, parallel numbers for the state of Maryland, not nearly as many unknown race and ethnicity. So that's good. 2.6% furthermost right column uptake so far in the white population, more closer in Black and other national race and ethnicities, 2% there. So those are some highlights and other detail you can see. The dollars spent 3.2, 2.5, again, similar to the previous slide. Next, please. Same type of information, but a different way to look at it and a zeroing in a little closer for the white population and African Americans and then the top and bottom. So the different way we're looking at it is, one, I think it gives hopefully outlines for use in upcoming slides. What are exactly the 7 conditions? And you can read them right here. Some of the top prevalence. The focus again is on prevalence, not just the universe, everyone who could get a test, but how many people in the white population in that first column were treated in 2024 for these 7, 8 conditions. So get a sense of who could benefit from these tests. How prevalent is there a difference by race and ethnicity for how many people were treated, and of the potential people that were treated who could benefit from a test, both in terms of early detection and targeted treatment? How many got a test in the unique testers column? So when we look at it this way and drill down to this next level, I'll ask you to please focus on the second to the rightmost column. It's 4.4% for the white population. And then the same thing down below, 2.8 for the Black, for the African American population. So there are some distinct a difference there. And when we look at disease by disease, I'll leave you to do that. But for example, highlight, let's say cardiovascular, rather autoimmune. So in the white population, 22% of people who typically get treated for that condition in a year got a test so far. And then for the parallel number for the African American population is 13.9. For cancer, it was a very high number, 66%, much lower, 37.8 for cancer for African Americans, etc. So in the full report, every race is presented this way, and you have more information, but wanted to give you a sense of what's available and what patterns we're starting to see. The last one I'll pull out here that I was curious about, back to the prevalence column, is I know that we've read research that certain genetic disposition to conditions, certain race and ethnicities are for heart disease, have more risk there, others for diabetes. And are we seeing that pattern here? For example, for, let's say, cardiovascular in the white population, 11% of that population were treated for that in a year, 9.7 for African American. And another one, behavioral, which is a very highly treated condition. Very few people are getting tested, at least in 2024, the first year. 37% prevalence, 0.1% got tested, and then 21% prevalence down in the bottom half, also less than 1% tested. Next slide, please.
Todd, what is ECT?
I'm sorry, expanded carrier testing. I know during pregnancy, genetic testing for inherited conditions without regard to race or ethnicity. Right. So it's separated because we consulted a few doctors in this report, put it in the metabolic category, but since it was so, I'm sorry if I'm being redundant for you, concentrated around pregnancy, it was kind of isolated and pulled out of the metabolic category.
Yeah. And in this table, if you look at the big chunk is oncology, and it's being overutilized.
Gotcha. Yeah, definitely. Next, please.
Do we know why the delta in testing between white and black?
We don't, but we're hoping to highlight it and you'll see as we come up, this is so new that additional monitoring is in the plans. But the answer so far is we don't. We've just identified it, quantified it, and tried to call attention to it.
From oncology perspective, I can tell you.
We hold questions
is
to the end. I mean, a few questions of clarity of the slides are fine, but let's have a more substantial discussion when the presentation is over.
Okay, certainly. Next, please. Next, please. So at a high level, we looked at how many people, for example, I mentioned 490 people in the large group commercial fully insured market. As you well know, 260,000 for the state of Maryland. That's self-insured. We looked at past patterns. We know HR1 and other things complicate moving forward the population, but we looked at past patterns and trended that forward for 5 years to 2030 with the best information we could. We showed you the 7 disease categories, actually 8 when you pull out expanded carrier testing. And we started with 24, the best empirical data we could get our hands on, and assumed that as we move forward 5 years, that 1.5% uptake so far in the large group market will grow up to 20%, 1 in 5 people getting a test by 2030. And looking at the best information we could glean, and the footnotes are in the report, these are not trending at typical 4%, these being the cost per test, and Dr. Bhandari, we saw a huge range. Behavioral cost per tests are very expensive. Autoimmune seem to be the least expensive cost per test, but they're all growing at 10.8% per year, both in the US and globally. So that you have a 10-8 trend on the cost per test going forward. Next, please. In that 5-year projection, the cost for the market for large group is $239 million. For the state employee market, as you see here, 150. I think it is important to highlight that that's 5 years. What is it for 1 year? And it will kind of geometrically grow. But for calendar 26, that 239 is about 18 million. And to put that into some context, it's about 1%, a 1% increase in total claims for that market, roughly. And there is the federal medical assistance, the FMAP, 63% or so federal help that could come into play there. So just wanted to mention those for further context. But those are not small numbers, but you have the context of 1% and the overall cost for 5 years estimated. Next, please. I'll just ask you to focus on where the numbers we looked at in the previous slide came from. They're from this slide and over to the furthermost right, the top half for large group, the rightmost corner bottom column. There's the 240 that I mentioned a minute ago. What I was curious about, so what are the big ones? And as was mentioned, 110 million for cancer, followed by behavioral health, 48 million, followed by 12 million for infectious disease, etc. I do think it's important too to try to take out that big number and take it down to 1 year. So for calendar 26, it's 18 million for a year. So when you bring in the federal match for that, it's more like 7 million. But again, the big ones are 9 million for cancer, 3 million for behavioral health, and 850 for infectious disease, and parallel numbers, $12 million for the state of Maryland for 1 year, for 5 years, and what we've seen so far in 24. Next, please. And I am almost done. So when you see these numbers, the reason you're seeing some different numbers is we were asked to compare this to the JCR that we did for Medicaid. As you know, that was on a fiscal year basis. Everything we've done here for commercial was calendar. So to put it on the same basis of fiscal, we had to just use 4 years and do this comparison. If you're wondering why the commercial market is so much smaller than Medicaid, maybe you're not, but as you know, the Medicaid market is about 1.5 million members versus the 490,000. So it's more than 3 times bigger exposure that could get a test. So that's one reason. And another is that, as Laura's slides indicated, that the ACA really treats small group separately and individual non-Medigap. So those aren't in this. So just if you're wondering why if you expected a bigger number, those are the 2 biggest reasons that explained it to me. Next, please. So again, why are we doing this? Trying to step back, fulfilling the report, but just in terms of how it could be used. About 31% of the large group market is treated in a given year for any of these 8 conditions, 48% in the state market and for the state of Maryland. So detecting early could benefit that large portion of the population as well as targeted treatment. And we did not incorporate any savings for that in the modeling. Definition is broad, and Dr. Jacobs helped us a lot with that. We did not include things like complete blood, the CBCs. We're trying to really focus on what did the legislation induce and proprietary tests and what is new per the legislation. Again, just emphasizing this is based on a single year. We expect big changes as the future unfolds and further monitoring. Next, please. So I'll turn it back to Laura if there's any, and the team, and we do appreciate your attention.
Laura?
Great. So I think that concludes our presentation. I guess we'll pause here for questions or comments.
Well, okay. Well, Laura and Todd, thank you very much. Just to do this appropriately here, do I have a motion to approve the mandated benefits study for HB 1217 SB 85 2023 Maryland Medical Assistance Program and health insurance coverage for biomarker testing to be submitted to the legislature?
So
Commissioner Jensen, second. Oh, okay. Commissioner Galrood, second. Is there any further discussion and questions?
Yes.
So Todd, what is the rationale of doing this is? I'm still puzzled what we are going to do with this one. If you go back few slides, oncology is going to break the healthcare system. Biomarker testing, this is, as I said, these are overutilized. Go another slide, please. And I can see, $2 million in 2024. So out of 3.1 million, 2 million is oncology. As you go in, total is out of 239 million is 110 million is oncology. It's being overutilized. We call it key opinion leader or the experts in the field. They are spreading the word. Everybody should be tested at every progression of the disease. We are really not catching a lot of, helping a lot of patients. We are basically trying to, it's going to be a problem with the healthcare system. And with this study, what the legislators are going to do, I can tell you, I'm a very practical person. I'm sure my colleague from Blue Cross Blue Shield will be concerned because this is being overutilized. Behavioral health, yes, small percentage, but oncology, which is a small portion, is taking the probably 50, close to 40% chunk of these, expenses.
Two things I think we would need, based on the report, if I understand it correctly, I would suggest that we need to add 2 comments. And one of them is that this report has not done any analysis of savings that are associated with this testing. So we can't say if it's overutilized or not if we don't know what we're saving, number one. If anything.
Quality outcome.
Yeah, savings broadly defined, absolutely, number one. Number two, as we talk in this commission about health equity, I think we really need to point out that this study doesn't do anything to explain the delta in usage between, as you described them, white and black, and that would probably, would be important to know just to factor in to our thinking. So that would be just adding highlighting 2 comments that you could figure out if you read this and you do the negative analysis. But I think they're worth putting spotlights on because I think they're important.
I just want to make sure how I'm thinking about this. So when we're talking about biomarkers, we're talking about solely prediction. And even if we are, I'm thinking out loud here. So I worked with a health plan for a health plan. And one of the things that we identified were that physicians or providers weren't always sure which biomarker test to be using. So they used a lot, or I'll say all, that was available to them. And so one of the ways we managed the cost was by having, I'll just say something simple like order sets that made it clearer for providers what tests to be used. And so I don't know if in this work we've been able to identify, I know it's cost per test, but is the overutilization because we're trying to predict for too many people, which in my mind would be a question of looking at the outcome on the other end of doing that, reducing, savings? Or is it because people are unsure what to do and they don't want to miss anything, and so they're just ordering a lot? Because it's a different solution.
Can I maybe chime in from a clinical perspective? So I will say, they mentioned this early on, but this definition of biomarkers, this question of what is a biomarker is underlying all of this. So I'm just going to read the definition again, just to emphasize this point. It's a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, pharmacologic responses to a specific therapeutic intervention, and it includes gene mutations, characteristics of genes, or protein expression. That means it's every hematologic test basically could satisfy that definition. And so the challenge here is that we're supposed to identify cost. Well, theoretically, all the carriers are already covering a complete blood count. But you could say that a complete blood count is a biomarker here. And that's why we saw, one of the slides showed one of the carriers thought that they didn't pay for a single biomarker in a single year. Well, if you look at that definition, that's impossible. So I think that, and that underlies all of this, because if we don't know exactly what the definition is, it's hard to like get our arms around some of these questions. So I just wanted to highlight that in particular, because this is not like a straightforward thing. And you'll see that our next presentation also covers pharmacogenetic testing, which should already be covered if you're looking at this definition. So it's like we're kind of asked these things by the legislature, but underlying it, there's a lot of nebulousness that we're trying to wrap our arms around. Go ahead.
Isn't that then an important footnote to also add? It says, perhaps that cost includes blood tests that are already being covered.
So for this one in particular, and I think
is one of your examples.
I think Todd had mentioned that basically what we tried to do to estimate the costs is because theoretically the carriers are already covering all like complete accounts. Like, so we tried to use those tests that we thought fell into this definition that weren't already being covered. So that's kind of underlying some of these numbers. But yeah, it's
but even a footnote that says that
that
we tried to factor out the tests that are already being covered because the definition is broad, but so that number doesn't get locked in as like
this is the
exact
number,
precise mathematically.
So would that be?
And
go ahead. I'm sorry.
I'm sorry. This is Commissioner Strawton Duncan. You touched on something that I think is very important, which is test utilization, which we discuss quite often in laboratory medicine. But I do agree with that definition being so broad. It is very hard. And Dr. Jacobs, to your point about, yes, a complete blood count technically could fall, under the biomarkers, but test utilization and the use of it is such a bigger conversation that it just aligns with so many other factors with the physicians in laboratory medicine. I think it makes it a little not as straightforward, but I do agree with adding that footnote so that it's a little clearer as to what tests came into those calculations.
And Dr. Jacob, I will give one more suggestion. Why oncology is so expensive? They do next-gen sequencing. Each test, NGS, there is a big panel. They do 600 genes, only 5 or maybe 2 genes are applicable, cancer-directed treatment. 590 genes has no value. Basically, they charge $5,000 to $21,000 or $30,000. And then they're saying every patient should get multiple tests done during their treatment for the cancer. Ideally, it should be one time, but it's a Wild West. You can do 10 times, you can do 20 times, nobody asks you. That's adding the cost. That's why these millions of dollars are going. I do this day in, day out. I'm a very responsible physician, but do I get rewarded or being told I'm a responsible physician? No. More tests the doctor does, the patient think they are the better doctors. Every month you are a better doctor. So these things we don't have in this setting. We don't know whether the patient was testing one time or multiple times, during their course of treatment.
And I'll just add that you're right. In 2024, the average number of tests per utilizer was 1.5. I mean, it differed so definitely people are getting more than one. And also, in my 2 cents of opinion, one of the most focal points and hopefully useful parts of the report is Appendix C, the full report, where we list all the CPTs that do define biomarkers. We started with about 275. You'll see in the report, it's about 150 CPTs. To scrub that again to make sure we all agree this is a biomarker.
Maybe I'll just suggest, so we can move us along, is something that MHCC could do is work with Hilltop to kind of like further highlight the broad nature of this definition and like the challenges with trying to estimate that. And we could either do a cover letter or like highlight it more in the report. So that could be one of the conditions of approval of this. And we could work on that before publication.
Could we just add to that the idea of health equity and the idea of downstream cost savings? Just so that lay legislators reading it would get some context that.
Great idea.
And Dr. Jacob, it should be mandated only one-time testing, especially in oncology. More you do it, more multiple times you do it, it adds multiple times the cost of testing.
we don't have the authority. to
Yeah, I
regulate
don't-
that, So we could just talk about that's an issue that needs to be looked at, right? I mean, the number of tests per patient is also not broken out, so that's another.
Number of times. It's not the number of tests. Number of times the same test is done,
Yeah.
I think that's probably not our specific charge with this, like from the legislature with this study, but we could perhaps like point to something about that in the report. Yeah.
Well, if we're going to make a change to the motion, you want to suggest language that essentially that we need to add, that we've agreed to add.
You want to do it? You want me to take away?
Go ahead. Yeah.
I move that we approve the report with a cover letter that Dr. Jacobs would prepare in conjunction with Hilltop that would highlight the impact of the broad definition of biomarkers testing, right? Number one. Number two, that would highlight the lack of data to determine why there's a difference in utilization between Black and white. And three, that the study does not address any savings to the healthcare system based on the use of these tests. So now I'm done, but anybody can feel free to correct or change that because I was kind of making it up as I went.
Did you get the whole one? I didn't get three there.
It doesn't address the savings, is that what you said?
Yeah.
It doesn't address the savings associated.
It's a broad definition. It's the healthcare equity issue. It's the savings to the system based on the use of the test, and then something that you had discussed, which was talking about the time, either the number of tests, either the same test or different tests per patient.
Utilization.
Yeah.
So
And anybody could say it better, have at it.
I can't say it better, but I struggle when we look at equity. I think it's a structural inequity when we look at equity as Black to white or white to Black. First of all, maybe if you're Asian, you're the best of all. So this, like the whole thing, if we're talking about equity, we should break out by different groups, because what if the difference between Black and Asian or Black and Hispanic or white and Asian or white and Hispanic is even bigger than Black and white? And so I feel like that builds a structural problem into how we define equity.
I think they may have done that.
I saw some, but what we have at the top is more white and the Black.
Yeah,
Black is at the bottom. I mean, it's clearly the big focus.
The full report has all the races.
I agree with you. The reason I referred to Black and white is because that's what they've got on their chart.
It look like I saw that you had some other things, but everything we talked about here was Black to white. And so for me, we need to acknowledge, well, if you're Hispanic and it's equally bad, why aren't we addressing that? Or
What do you
almost
think
as
about it, just including that in that cover letter?
Yeah.
I think it was in the report, though.
It is. It's in Appendix D.
And they're not going to get the slide set. They're going to get the report, the legislature. Yeah.
Okay.
That's fair.
Okay, just so procedurally, we have a motion to approve the report with a cover letter prepared by the commission in conjunction with Hilltop to highlight the broad definition, the lack of data or the lack of data explaining the differences between Black, white, and other ethnic groups, and that the report doesn't address any savings that would derive from the testing. So
moved.
okay.
Is there a second?
Second?
Seconded.
Okay. All in favor?
Aye.
Anyone opposed? Anyone opposed? Okay, the amended motion has passed. So thank you very much, Laura and Todd.
Thank you.
Great, thank you.
Okay, agenda item number 6, mandated benefit study for SB 961, the Maryland Medical Assistance Program and Health Insurance Pharmacogenomic Testing Required Coverage. And Insurance Article 1501 of the Annotated Code of Maryland requires the Commission to annually assess the medical, social, and financial impact of proposed mandated health insurance services that failed to pass during the preceding legislative session or as requested by a legislature or legislative committee. Commission staff received a formal letter of request from the Senate Finance Committee on April 9th, 2025 to evaluate SB 961 required coverage for pharmacogenomic testing. MCC staff contracted with Barry Dunn, an actuarial consulting firm, to assist with this evaluation. Dina Nash and Lisa Kennedy with Barry Dunn will present the findings of the study. So Dina and Lisa, you're there. Please proceed.
Thank you, Commissioners and Dr. Jacobs. My name is Dina Nash, and I'm a manager at Barry Dunn, and I'll be presenting this afternoon with my colleague Lisa Kennedy, who is an actuary and principal at Barry Dunn. This presentation reviews the findings from our evaluation of Senate Bill 961, which would require coverage of pharmacogenomic testing, also known as PGX testing, for individuals diagnosed with anxiety and depression. Our presentation is structured into 4 sections: the overview and legislation, the social evaluation, the medical evaluation, and finally the financial evaluation. Next slide, please. First, we'll go through the overview and legislation. Next slide, please. So the bill defines pharmacogenomic testing as laboratory genetic testing, including single gene and multi-gene panel testing, constructed to evaluate how an individual's genetic profile may impact the efficacy, safety, or toxicity of medications. These tests look for genetic variants that shape how someone metabolizes or responds to specific medications, which can affect both treatment outcomes and the likelihood of side effects. Clinicians use the results to inform prescribing decisions for antidepressants, including selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors, or SNRIs, so that selected medications better align with each patient's genetic profile. Next slide, please. So Senate Bill 961 was introduced in the 2025 legislative session and would require commercial insurers and Medicaid to cover PGX testing for people diagnosed with anxiety or depression. The bill builds on the biomarker coverage requirements in Chapter 322 of the laws of 2023, but it addresses a gap in how these requirements have been applied. PGX testing is scientifically a biomarker test, yet insurers have varied in determining whether PGX testing for anxiety and depression meets evidence and medical necessity standards. By explicitly requiring coverage for these indications, the bill clarifies legislative intent and places Maryland among the first states to specify PGX testing for anxiety and depression in a coverage mandate. Next slide, please. Now we will review the social evaluation. Next slide, please. So anxiety and depression are among the most common mental health conditions in the United States. When untreated or poorly managed, they can impair functioning, relationships, and overall quality of life. Antidepressants such as SSRIs and SNRIs are first-line treatments, but patient responses can vary widely due to genetic and environmental factors. PGX testing aims to personalize prescribing by identifying genetic variations that affect how individuals metabolize or respond to antidepressants, potentially minimizing the number of medications tried and reducing the time to effective treatment. Next slide, please. Providers most often order PGX testing for patients with treatment-resistant depression or anxiety, or a history of poor response to one or more antidepressants. Testing is not commonly used for first-line treatment, largely due to limited coverage, mixed evidence, and cost barriers. The eligible population under the bill includes individuals diagnosed with anxiety or depression who are prescribed or considered appropriate to receive antidepressant therapy. Given the high prevalence of these conditions, this represents a large potential population, but actual testing rates would depend on clinical adoption and insurer criteria. Next slide, please. So here we show an example of how PGX testing could fit into real-world practice. Typically, a person is diagnosed with anxiety or depression and starts an antidepressant. If the medication isn't effective, the provider might order a PGX test. Based on the results, the provider might adjust the dose, switch medications, or continue monitoring the patient. PGX testing is most often used after one or more unsuccessful antidepressant trials and can be initiated by psychiatrists, primary care providers, or pharmacists experienced in pharmacogenomics. Effective integration depends on providers' ability to interpret test results and follow evidence-based guidance. A 2022 review found that 57% of individuals who received PGX testing had already tried at least one antidepressant, while only 30% began treatment after testing, showing that PGX testing is most often used reactively rather than proactively. Next slide, please. In February 2023, 27.3% of adults in Maryland reported having experienced symptoms of anxiety or depression. Anxiety and depression are more common in certain populations, such as individuals insured via Medicaid. Anxiety and depression can reduce productivity and increase absenteeism, leading to substantial social and economic costs. Effective treatment can alleviate symptoms. Despite the widespread use of antidepressants, utilization of PGX testing appears low, as according to a 2022 study, fewer than 1% of patients experiencing depressive episodes had undergone PGX testing. Next slide, please. Current PGX testing coverage is inconsistent across insurers. Commercial insurance coverage remains limited and varies widely. Many large insurers classify PGX testing for mental health as experimental or as not medically necessary and therefore do not provide coverage. Medicaid programs are not required to cover PGX testing and typically approve it only on a case-by-case basis. Although out of scope for this study, we found Medicare coverage is limited to PGX testing for drugs with known gene-drug interactions with a Molecular Diagnostic Services Program, or MolDX. The result is highly variable coverage access depending on insurer and indication. Next slide, please. So access to PGX testing is uneven and often tied to insurance coverage and provider expertise. Several insurers consider PGX testing to be experimental and not medically necessary and thus do not provide coverage. Some insurers cover PGX testing but impose prior authorization or cover only a subset of PGX tests. Providers might be reluctant to order tests due to uncertainty about clinical utility or a lack of training in interpreting the results. Improved provider education, clinical decision support tools, and consistent coverage could increase the demand for PGX testing. Next slide, please. Thank you. So now we will briefly cover the medical evaluation. Next slide, please. So evidence on the efficacy of PGX testing for anxiety and depression remains mixed. Studies consistently show that PGX testing can improve short-term remission rates and reduce time to effective treatment, but long-term benefits are unclear. Limitations in study design, such as small sample sizes, an absence of study masking, and potential bias make results difficult to generalize. Insurers and policymakers continue to view PGX testing for mental health as promising, but not yet fully proven in terms of cost effectiveness and sustained benefit. Now I'll turn it over to Lisa to discuss our financial evaluation. Next slide, please.
Thank you, Dina, and good afternoon, everyone. I'm going to discuss the financial evaluation that we performed, but I'm going to preface it with just a description of what an actuarial estimate is and is not. It's based on theory, data, and assumptions developed using professional judgment and experience. And by definition, an actuarial assumption is an estimate of an uncertain variable that goes into financial modeling for the purpose of calculating insurance premiums or benefits. And because these estimates deal with the future, uncertainty is always a part of the equation. The next few slides provide a high-level summary of the financial analysis and resulting impact coverage of pharmacogenomic testing for anxiety and depression would have on public and commercial insurance costs should the bill pass. The details supporting these estimates can be found in the full report. Now we're going to talk about the overview and the methodology. The first step of the analysis was to identify the applicable insurance and patient populations impacted by the bill. The proposed mandate applies to state-regulated insurers, which includes fully insured commercial insurance purchased by individuals and employer groups, and Maryland's medical assistance program encompassing the managed care, health choice program, and fee-for-service. For simplicity, I'll refer to the medical assistance program as Medicaid. While self-insured health plans are not required to follow state mandates, the state employee health plan voluntarily follows state mandates, so they were included in this analysis as well. Insured enrollment for these market segments was sourced from Maryland's Medical Care Database, or MCDB. The potential patient population was determined to be insured individuals with anxiety and depression. The second step was to identify the services that would be covered under the mandate. As Dina mentioned earlier, PGX testing is technically included, but generally not covered under current biomarker mandate. So the impact of the mandate would expand insurance coverage to include PGX tests when ordered by a physician for individuals with anxiety and depression. The next step was finding data resources to inform assumptions for anticipated utilization and cost of PGX testing. We used claims by market segment sourced from Maryland's Medical Care Database. Carriers were surveyed and supplied information on coverage of PGX tests and premium levels. Some carriers indicated PGX testing is not considered medically necessary and so do not cover the tests. Other carriers indicated single gene PGX tests were covered, but not multi-gene tests. And some carrier responses indicated PGX tests are approved for patients experiencing moderate to severe depression and anxiety and have experienced treatment failure. Interviews with industry experts were also conducted. In addition, literature on PGX testing was researched. We analyzed claims data to estimate the current number of patients receiving coverage for PGX tests currently. We used information from carriers on PGX claims that had been denied to develop a range for the anticipated increase in patients if coverage expands and prior authorization requirements were relaxed in the event this mandate passes. We then analyzed the base period claim data to develop an estimate for the cost of PGX tests. Retention factors were applied to the incremental claim cost per member per month to calculate the incremental PMPM, or per member per month, impact to fully insured commercial premiums, state health plan premium equivalent, and Medicaid program costs. Next slide, please. This slide summarizes the current and projected utilization of PGX tests. We saw that utilization is currently higher for Medicaid than commercial. This could be due to higher rates of mental health conditions among Medicaid enrollees, as well as higher levels of psychological distress, which may contribute to greater demand for testing once individuals seek care. Overall, current utilization is fairly low, possibly due to limited carrier coverage. Across market segments, less than 1% of the population receives these tests annually. Our projected utilization levels aim to capture increased coverage of these tests, as well as the potential impacts of relaxed prior authorization requirements. Next slide, please. As mentioned earlier, there is inherent uncertainty in any projection, and this mandate study is no exception. There were several limitations to information available for this mandate study and factors we considered but could not quantify. Some of those limitations and considerations are highlighted on this slide. For example, the base period claims were limited due to variations in carrier coverage decisions, which caused volatility in the cost per test and in utilization rates across tiers. The effect of increasing awareness of PGX testing is unknown and could increase utilization higher than projected in these estimates. Historical enrollment in the market segments is impacted by the Medicaid continuous coverage during the public health emergency and the subsequent unwinding of continuous coverage. The estimate shown in the next few slides summarizes the results of our modeling of the incremental impacts of the PGX testing mandate would have on insurance costs if the bill is passed. Next slide, please. This slide summarizes the range of estimates for the fully insured individual and employer group populations. As you can see, for this population, the mid-range incremental premium cost due to the mandate is 4 cents per member per month, or 0.007% increase on the premium. And if you are interested in the dollars, we were estimating around 400,000 as our mid estimate for the impact of this mandate should it pass. Next slide, please. This slide summarizes the range of estimates for the Medicaid population. You may notice the incremental cost to the Medicaid program is a bit larger than the estimates for the commercial insurance. This is driven by higher utilization in the base period for the Medicaid population relative to the commercial insurance. The mid-range estimate for Medicaid is 9 cents per member per month, a 0.021% increase in the program costs, or approximately 1.8 million. Next slide, please. The estimated increase to the state employee health plan costs is slightly larger than the fully insured commercial, with the mid-range incremental impact of 5 cents per member per month, which is a 0.007% increase to premium equivalent, or 120,000. Next slide, please. So what are the key takeaways from this mandate study? Insurance carriers cited a lack of evidence supporting the medical necessity of PGX testing, which influenced their coverage decisions. The efficacy of PGX testing for individuals with anxiety and depression is uncertain across long periods of time. Future utilization of PGX testing is uncertain. And across the market segments, we do anticipate that this mandate would increase costs, but the degree is uncertain. And that concludes our presentation.
Thank you, Dina and Lisa. Do I have a motion to approve the mandated benefits study for SB 0961 Maryland Medical Assistance Program and Health Insurance Pharmacogenetic Genomic Testing Required Coverage to submit to the legislature?
So moved.
Jensen,
Seconded.
seconded. Commissioner Foreman. Is there any discussion? Questions? Oh, didn't see you, sorry.
Hello. Commissioner Gilreath, so how can or who can fund real robust research? Because in New York, this is covered by several carriers. I don't know about Maryland. And I have seen people who have been refractory to treatment, who have had the test and medications changed, whose lives have been turned around amazingly. And so it looks like we think we don't have robust peer-reviewed kind of research to prove a point of whether it's helpful or not, but it seems like we should, because if we think about parity for behavioral health versus other diseases where we are talking about this exact thing, I think that we should have the data required to give us the comfort we need to be able to know if this should be covered.
I can chime in if others do. Does anyone else have initial thoughts? I can basically just this, and this is from my previous role. At HHS, oftentimes we would cover certain studies like that. It would be like if it's original research, NIH would typically do some of that work. So, or a lot of it could be funded by the whoever is coming out with the drug itself or the test itself. So oftentimes, in this case, it would be the company that is creating the pharmacogenetic test. They might want to fund like a randomized controlled trial that has some of that work. But that would be my like off the cuff. I don't know if anyone else has additional insights.
Are there any other discussion, questions, thoughts? Okay.
I think I will say we should emphasize more on the preventive care rather than these testing are okay, but more emphasis should be about the fundamentals of the disease, how to prevent it. And that's where the role of the primary care is going to be.
So, okay, we have a motion. All in favor? Anyone opposed? The motion has passed. Thank you very much. Okay, agenda item number 7, mandated benefit study for SB 0508 Maryland Medical Assistance Program and health insurance required coverage for aesthetic services and restorative care for victims of domestic violence, Healing and Scars Act. The commission staff received a formal letter of request from the Senate Finance Committee on April 9th, 2025 to evaluate SB 0508 required coverage for aesthetic services and restorative care for victims of domestic violence. The staff contracted with Barry Dunn, an actuarial consulting firm, to evaluate the cost of requiring coverage for aesthetic services and restorative care for victims of domestic violence. Valerie Hamilton and Lisa Kennedy with Barry Dunn will present the findings of the study before asking the commission to approve the report. So Valerie and Lisa, please proceed.
Great. Thanks so much. And thank you so much for the opportunity to be here. I'm Valerie Hamilton, a principal in Barry Dunn's Health Analytics Practice Group, and along with Lisa Kennedy, rejoining me for this mandate as well, actuary principal and the leader of our Health Analytics Practice Group, will present the aesthetic services and restorative care for victims of domestic violence mandated benefit review. Next slide. Before we begin, we'd like to acknowledge that today's presentation includes sensitive content related to domestic and intimate partner violence. We will discuss physical injuries, scars, and the long-term impacts survivors face. And before we dive into the review, it's important to note the limitations of the data for this report. Data was extremely limited, and the report scope did not lend itself to deep academic level analysis. Most of the sources used predate the pandemic and lack granular state level data. We supplemented these sources with broad literature review, recognizing that much of the research is based on small or specialized samples. And to further supplement and contextualize the limited available data, we conducted interviews with subject matter experts, including clinicians from Johns Hopkins, leadership from the Illinois State Medical Society, who is the only other state who has similar legislation, representatives from the Maryland Dental Action Coalition, the Domestic Violence Coalition at the Maryland State Medical Society, and a certified nurse midwife involved in statewide maternal health efforts. Our objective was to synthesize the best available evidence to inform decision-making while remaining transparent about these limitations. Next slide. I'll start with an overview of the bill and its legislative context, and then move into the social and medical evaluations. After that, Lisa will take it away with the actuarial review. Next slide. Next slide. The bill entitled Healing Our Scars Act was introduced in Maryland's 2025 legislative session and mandates Medicaid and state regulated insurers to cover medically necessary aesthetic, and restorative care for survivors of domestic violence. This is a targeted effort to close a coverage gap affecting survivors of domestic violence. Maryland insurers report covering what they deem medically necessary care, regardless of the cause of injury, to improve functionality, or also called restorative care. However, the gap remains for the aesthetic care. The ACA prohibits discrimination based on domestic violence experiences and requires insurance coverage for domestic violence screening. However, there is no federal coverage requirement for these injuries or the related care. Next slide. The bill defines a victim of domestic violence as an individual who has received or is in fear of deliberate, severe, and demonstrable physical injury from a current or former spouse or cohabitant. Consistent with Maryland's family law statutes, cohabitant is defined as a person who has had a sexual relationship and resided with the respondent for a period of at least 90 days within a year of filing a petition. Next slide. The CDC's definition of intimate partner violence is broader and widely cited throughout the literature. It includes any physical or sexual violence, stalking, and or psychological aggression by a current or former dating partner or spouse. The CDC's definition does not require sexual intimacy. For purposes of our report, Barry Dunn uses domestic violence, intimate partner violence, interchangeably incorporating both terms. Next slide. While insurers cover restorative care that improves physical function, our carrier survey indicated they frequently deny treatments aimed at improving appearance, often labeling them as cosmetic and therefore not medically necessary. Next slide. And next slide. In Maryland, about 38% of women and 35% of men will experience domestic violence, slightly below the national average of 42%. While rates are similar across genders, women tend to suffer more injuries and require more medical care. LGBTQ individuals, multiracial, and Black communities face even higher rates. Up to 80% of domestic violence-related injuries affect the head, the neck, and the face. Survivors often report lasting physical symptoms like pain or itchiness, and the mental health challenges, including PTSD, anxiety, and low self-esteem. Estimates by the U.S. Department of Justice suggest that about 47% of all domestic violence is not reported to the police. Domestic violence screening is not consistently implemented, and even when it is, results may not be documented in the health records. Many survivors don't feel safe or comfortable sharing their experiences, and additionally, attitudes towards surgery do not always correlate with actual utilization of surgery. Next slide. One study found that nearly 60% of domestic violence victims have at least one permanent mark or scar. Among individuals who seek care for residual injuries, most, or about 45%, seek care for scars, followed by broken nose, and 39%, and other residual fractures, 18%. A 2022 study found that individuals sought care on average over 9 years after the initial injury. Some initial injuries may not have been treated, which could also impact the healing outcomes. Generally, cost is a major barrier and why many people do not pursue cosmetic surgery, which also applies to victims of domestic violence. Next slide. Illinois is the only other state with similar legislation. In January of this year, similar legislation went into effect, requiring coverage for treatments that improve appearance and or functionality after an individual has experienced physical trauma. In comparison to the proposed Maryland bill, the Illinois mandate is much broader and does not apply to a specific population or type of physical trauma. Our review of Illinois carrier policies indicate that prior authorization is commonly required before treatment is approved. Also, since it just went into place in January of this year, it did allow for time to see, what the impact of that legislation was. Next slide. And next slide. Each type of injury brings unique physical impacts and treatment needs, but all forms of harm can carry psychological consequences. For example, visible scars, especially facial, can significantly affect mental health and self-esteem. Stress from domestic violence slows healing and weakens skin tissue, making recovery harder. Trauma is deeply personal, and for some, scars are painful reminders of violence. History and intergenerational harm or trauma, particularly among underserved groups, can intensify emotional harm. And recovery is not linear or one size fits all. Survivors need different types of care at different times. And now I will pass the presentation off to Lisa.
Thank you, Valerie, and good afternoon, everyone. I will start. Oh, next slide, please. We're going to talk about the financial evaluation, and I will preface this with a similar caveat that I used in the previous mandate study. Actuarial estimates are based on theory, data, and assumptions developed using professional judgment and experience. By definition, an actuarial assumption is an estimate of uncertain variables that go into a financial model for the purpose of calculating insurance premiums or benefits. And because these estimates deal with the future, uncertainty is always part of the equation. As Valerie mentioned earlier, one of the biggest challenges we faced when estimating the financial impact of the bill was the lack of comprehensive data and research on domestic violence and associated residual injuries. This resulted in more unknown factors than usual to consider when developing assumptions and ranges, which increases uncertainty. That's why the ranges we developed are wider than what you typically see. They're not meant to cover every possible outcome, but they do represent a reasonable range for the purpose of this analysis. The next few slides will provide a high-level summary of the actuarial analysis and assumptions used to estimate the impact of the Healing Our Scars Act would have on the public and commercial insurance costs should the bill pass. The details supporting these estimates can be found in the full report. The first step of the analysis was to identify the applicable insurance and patient populations impacted by the bill. The proposed mandate applies to state-regulated insurers, which includes fully insured commercial insurance purchased by individuals or employer groups, and Maryland's Medical Assistance Program, which I'll refer to as Medicaid. This includes both the Health Choice Program, which is the managed care portion, and the fee-for-service. While self-insured health plans are not required to follow state mandates, the state employee health plan voluntarily follows the state mandates, so we also included the state health plan in our analysis. Insured enrollment for these market segments, split by gender, was sourced from Maryland's medical care database. The potential patient population, victims of domestic violence, was determined to be adults aged 18 to 64. The second step was to identify the services that would be covered under the mandate. As Valerie mentioned, restorative services are generally covered by insurance plans and Medicaid. So the impact of the mandate would be coverage of aesthetic services to treat injuries resulting from domestic violence. The next step was finding data sources to inform assumptions for anticipated utilization and cost of aesthetic treatments for injuries caused by domestic violence. For reasons Valerie mentioned earlier, the prevalence of domestic violence and utilization of services by victims of domestic violence are essentially not identifiable in the claim data, so we researched literature for relevant statistics. The literature indicated higher incidence of domestic violence in the Medicaid population and higher rates of injury for female victims of domestic violence relative to male victims. Published estimates of the proportion of domestic violence victims who report permanent marks or scars were used as a proxy for those who might seek aesthetic services. The statistics were used to develop ranges for a series of assumptions, which were applied to the insured enrollment to estimate the utilization of aesthetic services by victims of domestic violence. To develop the cost of treatment, we researched the various aesthetic services used to treat injuries and found a wide range of services and associated costs. Treatments range from steroid injections to laser therapy to surgical removal. To develop the ranges for cost per user, we varied the service mix of surgical and non-surgical aesthetic treatments. We assumed one treatment per user per year. Retention factors were applied to the incremental claim cost PMPMs to calculate the incremental PMPM impact to fully insured commercial premiums, state health plan premium equivalents, and Medicaid program costs. Next slide. This slide shows how we narrowed down the total population to estimate the population that would seek aesthetic care. We started with the fully insured population aged 18 to 64. Then, based on literature, estimated the proportion of that population with an injury from domestic violence, then narrowed that population down to victims with residual injuries resulting from those injuries, then narrowed that population down to those who would seek aesthetic treatment for their residual injuries. The key assumptions in finding the proportion of the population that would seek aesthetic care include a higher prevalence of domestic violence for Medicaid enrollees, a variation in prevalence between men and women, and a range of uptake rates for aesthetic treatment. Next slide, please. There is inherent uncertainty in any projection, and this mandate study is no exception. There were several limitations to information available for this mandate study and factors we considered but could not quantify. Some of those limitations and considerations are listed on this slide. One is that we were unable to identify the claims related to domestic violence in the database for Maryland. So the assumed number of domestic violence survivors seeking aesthetic treatment for scars relied on a series of assumptions based on the literature. Since aesthetic services have not been covered, treatment costs and utilization of aesthetic services were not available to use as a baseline. Literature suggests domestic violence cases are underreported, so it's difficult to predict the impact of aesthetic services, the impact this mandate would have on the number of people reporting domestic violence and intimate partner violence. Historical enrollment in the market segments is impacted by the Medicaid continuous coverage during the public health emergency and then the subsequent unwinding of continuous coverage, which could alter the starting enrollment that we use for this analysis. The estimates shown in the next few slides summarize the results of our modeling of the incremental impacts of the Healing Our Scars Act would have on insurance costs if the bill is passed. Next slide, please. This slide shows our projected utilization of aesthetic services due to the passage of the mandate. The range of estimated new users as a percent of the total population is fairly small. We estimate that 0.01% to 0.02% of the commercial population and 0.03% to 0.08% of the Medicaid population will seek these services. As discussed earlier, we assumed a higher uptake rate for the Medicaid population than the commercial population due to greater prevalence of domestic violence for this population. Next slide, please. This slide summarizes the range of estimates for the fully insured individual and employer group populations. As you can see, for this population, the mid-range incremental premium cost due to the mandate is 6 cents per member per month, a 0.01% increase to the fully insured commercial insurance premiums. From a dollar perspective, this is approximately $666,000. The next slide summarizes the range of estimates for Medicaid population. You may notice the incremental cost to the Medicaid program is a bit larger than the estimates for the commercial population. This is driven by the higher incidence of domestic violence for the Medicaid population, as noted earlier. This mid-range estimate for Medicaid is 20 cents per member per month, representing a 0.05% of the program costs. From a dollar perspective, our mid estimate is around 3.9 million. Next slide, please. The estimated increase for the state employee health plan is similar to fully insured commercial, with the mid-range incremental impact of 6 cents per member per month, a 0.01% increase to premium. This represents approximately $150,000 per year. Next slide. So what are the key takeaways? Domestic violence can affect anyone, yet underserved groups experience higher rates of domestic violence and associated injuries. These injuries may not heal properly and can alter victims' physical appearance, which can negatively impact the well-being of domestic violence victims and may be a constant reminder of the domestic violence. Domestic violence is widely underreported, adding uncertainty to these estimates. How this mandate would be implemented adds uncertainty to the estimate as well. For example, what documentation will patients seeking aesthetic services have to produce to prove the scar is the result of domestic violence? Cost is also a major barrier to victims facing or trying to access aesthetic treatment to remove scars or to fix residual injuries resulting from domestic violence. Insurers will generally cover the restorative services, but not the aesthetic services. And this concludes our presentation. Thank you for the opportunity to present.
Well, thank you, Valerie and Lisa, for your presentation. Do you have a motion to approve the mandated benefit study for Senate Bill 508, required coverage for aesthetic services and restorative care for victims of domestic violence, Healing and Scars Act, to submit to the legislature?
Motion, Commissioner Duncan.
Commissioner Duncan. And second, Commissioner Gelrud. So are there any discussion? No questions. I have a couple of questions. One is, what is the, I don't doubt it, but what is the source of the higher incidence of domestic violence, IPV, for the Medicaid population?
That came from, just one second. We had two different sources. One was and I believe these are both in the report. One came from a report from Wiley that we believe was 42 states out of the US. And that estimated the prevalence ratio to be approximately 4.8 for Medicaid compared to employer-based prevalence. And then we had another report that was done out of Charleston, South Carolina, and that had a range that the ratio between Medicaid and employer-based is approximately 1.8 to 3.85. So using those two reports, we developed, we kind of looked at averages and we assumed a ratio of 4.5 to 1.
Thank you.
And we went on the higher end of the estimate because of all the uncertainty that exists with this study, especially the underreporting is a big concern of ours. That it's right now there's a lot of underreporting, but that could change in the future if this bill were to pass, and someone might be motivated to report that at the time that they want to have their scar removed. And just for reference, these are in our report. These are numbered 94 and 95 in the endnotes.
Thank you.
Yeah.
In your presentation, you're very, very clear about the caveats of the studies and the data, lack of data that you're working on, and it is in the report. But I just had a sense it could be clearer. The U.S. National Intimate Partner and Sexual Violence Survey, which is where you come up with a 40% lifetime. In the report, it doesn't really say lifetime until later, so that number had jumped out at.
Okay.
I think that would be good to clarify, but it seems to me all we really all we really know for sure is an estimated proportion of the national level or past year of IPV victims who received physical injuries and said they needed medical care. We don't know the nature of the injury or that the treatment required was aesthetic or not, nor cost of the specific treatments. I do think in the report, you can kind of put that together, but I think you need to have a clear statement of what data is, like the U.S. National Intimate Partner, that's something that is generalizable, where many of the other studies are too small. For instance, the 60% figure you quoted that had at least one mark was from a study of, very small group. I think it was 345 victims of moderate and severe IPV. And even we don't know the incidence. And the 9.26 years was based on 22 cases from domestic violence shelters and online forums. So I think just outlining the nature of the data kind of clearly in the report would be helpful.
Okay. Yeah, we can definitely work on that. And some of the statistics that we mention in the report aren't really factored into the calculation. They're more just for background and just to, I guess, help highlight, how difficult it is to actually, get a handle on domestic violence and how prevalent it is. And, there's just so many factors, especially with, with how the bill is written. There's a lot of uncertainty in how it would be implemented. And as we mentioned, what kind of proof would be required. But yeah, that the statistic of, it sometimes takes over 9 years for someone to report domestic violence, that really wasn't used in our projection, but it was kind of an indicator that, okay, it might not be immediately. So we felt we couldn't, we needed to use more of an annual statistic. And then, there could be pent up demand, for these services. So, initially the first year could be high. So we wanted to go kind of conservative on our estimates and make sure that our range was wide enough to account for some of these uncertainties.
Well, thank you. Would it be fair to say then that we have the motion and perhaps add a change that to clarify, more clearly in the report, the data that we do know and the data that we don't know and what is based on, very small, not projectable studies. I think.
Yes, we can definitely work on that with your team. What would be the time frame for?
Well, I think that we would just need to, and can be honest, I think it's just before the end of the year, right?
Yes, before the,
Okay.
before the end of the year, and Lisa, we'll
Okay.
work with you, we will have a call
Okay.
with you to really determine that.
Okay.
And I think this is just upfront, just clarity in the report.
Yes. Yeah.
Me too. Okay.
Yes. That sounds like a good idea. Thank you.
Okay. So we have a motion with a slight change. All in favor? Is there a second? I
We
thought
have
we.
to resecond it, I think, because
Oh,
you changed.
okay. We need
A
another
second.
motion. Okay.
You need it. So moved.
So moved.
All right, second.
Okay. Commissioner Calvin. Okay. All in favor?
Aye.
Is anyone opposed? Okay, well, thank you. The mandated benefits study. I will read the whole thing as the report is approved to submit to the legislature with the caveat that we discussed.
Thank you for your attention.
Well, thank you for a great report. Agenda item number 8 is a presentation update on HIE implementation of data sharing protections for legally protected health information. Chapters 248, 249, health, reproductive health services, protected information and insurance requirements enacted in 2023 prohibits the disclosure of certain reproductive health information by electronic health network and health information exchange entities operating in the state. Vendors report to the commission quarterly on their progress in developing the technical capabilities needed to support compliance. Anna Gribble, Assistant Chief of the Health Information Technology Division, will update the commission on the status of vendor implementation and outline possible next steps. So, please proceed.
Thank you, Chair. Good afternoon, commissioners. Nice to see everybody. Next slide, please. So during today's presentation, I will review legislation enacted in 2024 that established requirements for technology vendors to implement protections for certain health information, summarize vendors' progress to achieve compliance as well as their challenges, and overview next steps for 2026. Next slide. So since the Dobbs versus Jackson Women's Health Organization decision in June of 2022 overturning Roe versus Wade, select states have enacted laws to ban access to abortion and other reproductive health services. In response, the Maryland General Assembly passed legislation in 2023 that prohibits the disclosure of certain reproductive health information by electronic health networks or EHNs and health information exchanges or HIEs operating in the state. The reproductive health information currently includes mifepristone data and the diagnosis, procedure, medication, and other codes related to abortion care, and is referred to in the regulation and in the statute as legally protected health information, and we also refer to it as LPHI in this presentation. The specific LPHI codes are defined in the Maryland Department of Health Regulations, COMAR 10-1108. HIE and EHN vendors are required to develop the technical capability to filter and restrict from disclosure the LPHI codes and related text, as well as facilitate the exchange of LPHI when direct consent is provided. So over the past 2 years, staff have worked closely with vendors to develop regulations and offer guidance to support their implementation of new technical capabilities for LPHI. And most HIEs have been granted a time-limited exemption through December 2025 as they work towards compliance. So I will overview vendor progress in the following slides. Next slide, please. So through periodic implementation updates, vendors have demonstrated notable progress in developing the new technical capabilities for LPHI. So this has required re-engineering systems that are otherwise designed to promote seamless information sharing to enable certain data, this LPHI data, from being shared, so it has to be filtered and blocked. This process has been time intensive and more time intensive than the typical design changes these vendors implement, which are often generally aimed at expanding interoperability and access to data. Another challenge vendors face is that they cannot dictate when clients implement the software upgrades. So in health systems, user acceptance testing can take up to 24 months as organizations rigorously assess the impact of upgrades on clinical and operational systems. And vendors have reported that implementing the unfunded mandate has led to unanticipated costs that they must absorb. Next slide. So this table highlights progress vendors have made to develop and implement the LPHI technical capabilities. The check marks reflect where vendors are today and when they anticipate achieving full compliance. So the roughly 41% of vendors who are fully compliant tend to be the larger EHR software developers or the traditional HIEs like CRISP or the Delaware Health Information Network. So these vendors have demonstrated flexibility in implementing new technology requirements and have actually provided helpful insight for others in the process. The rest of the vendors in that middle column have indicated they are working towards compliance by the end of 2026. These vendors tend to have fewer clients in the state, be newer to market, or support specific provider types like long-term health care facilities. So the law does allow fines for non-compliance, and vendors who do not fully implement the requirements for LPHI by the end of 2026 may be subject to penalties. Staff spoke to certain vendors whose September implementation update initially included timelines that may have potentially extended into 2027. Those vendors have since updated their approaches and timelines based on those discussions, and some have even hired third-party contractors to expedite the work. Vendors have expressed confidence in preparing to achieve compliance in 2026. Staff will continue to monitor vendors' quarterly implementation updates in 2026 to assess that progress. Next slide, please. So staff will continue providing consultative guidance where appropriate to help vendors implement the law. And vendors have been advised that staff will begin calculating fines in 2026 for those who are not fully compliant. Fines will only be assessed beginning January 2027 if vendors have not yet come into full compliance. The law permits MHCC to assess fines of up to $10,000 per day based on criteria established in law, which is also listed on this slide. Next slide, please. For next steps, staff will review vendors' quarterly assessments of progress and provide updates to the Commission. Staff will continue participating in meetings with the Electronic Health Record Association, which represents most of the registered HIEs in Maryland, to participate in roundtable discussions related to addressing technology or policy challenges. And staff will monitor the planned expansion of the scope of LPHI given the Department of Health's plan to amend COMAR 10-1108. This is in response to a recommendation from the Protected Healthcare Commission to add 5 new gender-affirming care diagnostic codes. So as a reminder, the Protected Healthcare Commission was established in the 2023 law with the purpose of making recommendations regarding the sensitive health services that should be determined by the Secretary to be legally protected health information. And amendments to COMAR 10-1108 are anticipated to be finalized by the end of Q1 2026. Earlier this year, most vendors expressed a commitment to beginning working to prepare for the implementation of the new gender-affirming care codes. Next slide, please. So thank you, Chair and Commissioners. This concludes my presentation. I'm happy to address any questions you may have.
Thank you very much. I think it's amazing to see the kind of progress that's been made.
They've worked very hard towards it.
Yes. It's been a good work on your part, on the Commission's part as well. Any questions? Thank you very much. Appreciate it. Agenda item number 9, overview of upcoming activities. And Doug, would you like to share?
Sure. In the next meeting is the last of the year, and typically there's a lot of, we have to get a lot of these reports done by the end of the year. So part of why you saw a lot of reports today was for that reason. The reports need to be done before the end of the year because the legislature uses them in their next legislative session. So there's additional reports coming up for this next December meeting. And so one of the agenda items is an insurer and provider concentration study. We've solicited a lot of feedback from different stakeholders on that, and that will be presented then. There's going to be a report on the Maryland Trauma Physician Services Fund annual report, and that's the fund that the Maryland Healthcare Commission administers to trauma centers throughout the state. Next, there's another report about two-sided incentive arrangements and capitated payments. And then there's also another mandated benefits study related to screening for ovarian cancer and cervical cancer. And then there's a presentation about the most costly prescription drugs in the state. And so with that, that will round out the commission meetings for the year.
So there'll still be a lot of reading to do.
A lot of reading. Yeah.
Thank you. Well, do I, agenda item number 10, motion to adjourn. Do I have a motion to adjourn the public commission meeting?
Before we do that, I just had a question.
Yeah.
And it's not just related to this set of reports, but over the years, there's a lot of requests for studies from the legislators. And I just was interested in what our process is to work with them, to ask the questions that really get to what they're trying to learn for the answers, right? Because people don't usually know what data they need to be asking for. And then we do a lot of reports and we find ourselves talking about, well, so how do we make this more meaningful? I mean it all in a positive way, like, even though I don't feel like I'm sounding it as positive as I mean it. But I loved, for example, that you sat with one group to decide what tests were in, what tests were out. You did that with our consultants. But what's the process to do that with the people who are actually asking for reports so that they get something actionable?
I love that question. I think that's a great question because it also speaks to like how do we be more proactive with like the work that we're doing and presenting for all the commissioners. So I'll start, Kenneth, if you want to jump in. My understanding in my short time here is there's a few mechanisms for when we have to do these studies. One is there is legislation that basically says the Maryland Healthcare Commission has to do a study whenever a mandated benefit law fails to pass. So not when it passes, when it doesn't pass. And so oftentimes a lot of these studies that we're doing are informing the next legislative cycle. So for example, the studies today on coverage for aesthetics, domestic violence and services to address the complications from that, and then also the pharmacogenetic testing, those did not pass. And so we're doing those studies because we have to. There are also separate letters that we get from the chair of the House Government and Operations Committee and the Senate Finance Committee that specifically request certain studies. And that is, so like the study that you're going to see next time on market concentration was one of those letters. And then and so to your point though about like how do we kind of work with them to make sure we're asking and answering the right questions, I will say I'm starting at a certain point in time, so I wasn't there for the like previous like legislative session, so that's why I'll refer to Kenneth in a moment. But one of the studies that we were asked to do this year, for example, was coverage of postpartum depression screening. I will say that postpartum depression screening is already required to be covered by federal law and state law because it has a USPSTF grade A or B rating, and the Affordable Care Act says you have to cover those already. So it seemed a little silly that we would be doing a study based on something that is already covered. And so we actually went back to the legislature and says, like, there's a kind of a conflict here. Is this really what you wanted? And we got back that, oh, we could actually just send them a letter saying this doesn't really make sense. And we kind of did that. So what we're going to try to do, I think, is through this process this next year is be a little bit more proactive with the legislature so that we're doing really meaningful studies and answering the questions that they want us to answer. But yeah, I just really appreciate that question. Kenneth, do you want to add anything?
Yeah, and also, Dr. Jacobs, also studies that have already passed. Sometimes we have a study that passed, but we don't have enough information as the impact of that study.
Right.
Right. So also the legislature will send us a letter say, well, this has passed, but we don't know the impact. So could you do a study, of the year ahead as to what we could expect that particular legislation to actually.
And a good example of that one is the biomarker study. So the biomarker legislation already passed. That is already a mandate in effect, and the legislature is saying, what is going to be this impact from a cost perspective? And so that's why I was trying to point out some of the tie-in to the pharmacogenetic testing, because if we've already passed biomarker coverage, and that definition includes pharmacogenetic testing, then we're also doing a study now on whether the state should cover pharmacogenetic testing. So it's a little bit of like this interesting kind of dynamic. And I just appreciate the kind of zoomed out nature because I think these interplays are really important. And we want to be giving the legislature the answers to their questions, yes, but also to the questions that are not exactly asking, but we think that they mean.
Exactly.
Yeah.
That's where my head was. And just to comment one step further, when folks are asking a question, they're asking for something like this box, and they're forgetting the impact over here. So whether that means 3 years, 5 years, 10 years, right? So if you look to our point, we said we need to look at the health outcomes or the change in financials when we do biomarkers, because what we're doing today is really impacting tomorrow. But I'm not sure if every legislation person who's asking for stuff knows to ask for that, right? So in my experience of 100 years in healthcare, you kind of have to sit with people and say, tell me what you really want to know so we pull the right data, because we otherwise are answering this question with a lot of resources and not getting to something over here that might be equally or more meaningful.
Yeah.
I'm actually surprised the biomarker study passed, given some of the questions, but it did.
Yeah.
So,
thank you.
Good question. Any other questions before I try to adjourn the meeting? Sorry. No, that's good. Okay, do I have a motion to adjourn the public commission meeting?
So moved.
Oh, okay.
Second.
Aaron and Mark. We have a second to all in favor? Anyone opposed? Okay, the meeting is adjourned. Thank you. Before you go.
I have some questions.
Yes, good meeting.
Thank you.
It's an anecdotal thing.